This OGD of a patient with food impaction, feeling of dysphagia after a meal. We suspect that the patient has food impaction. The patient, he's 49 years old, and he underwent fundoplication 30 days ago. Then after discussion with the patient and family and taking informed consent, we decide to do gastroscopy as diagnostic and therapeutic if possible. When we do gastroscopy in the esophagus, we found that there is large meat piece in the lower part of the esophagus. Our plan in this moment is, if we can bypass it and reaching to the stomach and looking for the GE junction, and if we can assess the GE junction and found that it is good enough that we can push the food into the stomach, we can do that. If we cannot do that, our next plan or plan B is to do removal from the mouth. So we can bypass the food portion, then we enter to the stomach, we assess the stomach, we assess the duodenum, which was normal. Then we assess the GE junction by retroflexion. We found that the wrap is present and intact and it's not tight, so we decide to do the plan A, which is pushing the food particles to the stomach. This is the duodenum of the patient, which is normal. Then we return back to the stomach. There's excess saliva in the stomach. We assess the GE junction where the wrap is present and intact, but it is not tight. So we decide to push the food particles to the stomach. So this is the plan when we facing an emergency case with food impaction, to assess the distal part to the food portion, whether it is intact or there is mass or there is structure, to avoid pushing the food particles against the structure or mass that can cause harm for the patient. So at this moment we decide to do pushing the food particles to the stomach. We cut that. Then this is the meat portion present in the stomach, and this is the end of the procedure.